Black women in America are 40% more likely to die of breast cancer than white women.
We coined the term oncologic anthropology to try to explain these patterns.
Dr. Lisa Newman is the reason more Black women are being seen, studied, and saved. This is one episode you don't want to miss.
Triple-negative breast cancers are even more prevalent among women in Western Sub-Saharan Africa.
This isn't just about biology, it's about a system that has failed us.
All patients will have more faith in the healthcare system if they see healthcare providers that reflect their own families and their communities. My sister Debbie, she had brain metastases from triple-negative breast cancer. We've made wonderful strides in treating breast cancer, but none of them were in time for Debbie. With AI, we have the promise of utilizing many thousands of data points to try to predict who is going to develop a cancer. When we meet newly diagnosed breast cancer patients, we generally can tell them, you can beat this. We have to stop the silence, talk about it, and take action.
Dr. Lisa Newman is the reason more Black women are being seen, studied, and saved. She's not just a breast surgeon, she's leading the global fight in the Black breast cancer crisis. Dr. Newman is proof that research, representation, and relentless advocacy can change outcomes, and she's just getting started. This is one episode you don't want to miss. Dr. Newman, thank you so much for being here for our podcast. We couldn't do it without you. It's our inaugural podcast, and you have been 10 toes down with Sisters Network, a champion of us for 30 years. So we couldn't do this without you. Thank you so much for being here.
Oh my goodness. I am the one who is so incredibly grateful. It is such an honor to be with you today, Colleen. Yes, the last 25 plus years we've been working together, and it's just been a thrill to be playing a small role in the huge things that the Sisters Network Incorporated has accomplished in terms of empowering the African American community regarding breast cancer disparities and making strides in reducing those disparities and understanding those disparities through screening, education, community awareness. Thank you for what you do, and thank you for letting me be a part of it.
Well, let's just jump right into it. What is the state of Black women and breast cancer today?
Whew. I can think of so many adjectives to answer that question. Challenging, painful, difficult. On the other hand, promising. We have so many exciting technologies at our fingertips that can help us to diminish breast cancer disparities, the higher mortality rates that we see between African American women and white women. We have so many research strategies that can help us understand why the biology of breast cancer seems to be different in people of African descent compared to people of European descent.
Right.
The higher rates of the biologically aggressive triple-negative breast cancers, the higher population-based incidence rates of male breast cancer in the African American community compared to the white American community. And we do have the research tools in terms of genetics, genotyping, AI, so many different tools that can help us to understand these disparities. And we have strategies for early detection and better treatments that can help us to mitigate these disparities. On the other hand, a lot of our progress is limited because of a lack of funding for research, and the funding opportunities are diminishing further and further. So we have a lot of work to do in order to take advantage of the research tools that are available to us that can help us to eliminate these disparities.
I know that your research has taken you not only domestically, but abroad. What are some of the findings that you have discovered with Black women, particularly young Black women in breast cancer?
Yeah, thanks for asking. It has indeed been quite a journey geographically and emotionally in every way that you can think of over the past several decades, and the opportunities that I've been honored to be involved with in terms of research. And in looking at some of the basics that describe the breast cancer burden of African American women, we have had clues for several decades that there were genetic issues at play. As you mentioned, the younger age distribution of breast cancer in Black women compared to white women, the higher rates of biologically aggressive tumors. Those types of features absolutely made us concerned that African ancestry in and of itself is associated with a hereditary susceptibility for certain patterns of the disease. And that's why we were motivated to work on the continent of Africa to study the breast cancer burden of women on the continent of Africa. And Africa is a huge continent, obviously,
Absolutely.
and it's the homeland for all of mankind. So it has tremendous diversity in terms of the way that African communities live and their environmental exposures, diet. So we knew early on that we were going to need to study breast cancer on different regions of Africa. So in particular, we've been looking at the breast cancer burden of women from Western Sub-Saharan Africa compared to women from East Africa. And we've made some striking observations. One of the things that we've seen early on, and it's been consistent over the past 20 years that we've been doing this work, is that these biologically aggressive triple-negative breast cancers are even more prevalent among women in Western Sub-Saharan Africa, but they're actually uncommon among women in East Africa.
Why is that?
Well, we coined the term oncologic anthropology to try to explain these patterns.
Okay.
We see the higher rates of triple-negative breast cancer in African American women. And if you think back to grade school social studies, you'll remember the transatlantic slave trade several hundred years ago brought the ancestors of contemporary Western Sub-Saharan Africans across the ocean to serve as slaves in the colonies. And so as contemporary African Americans, we actually have quite a bit of shared ancestry with Western Sub-Saharan Africans. The East African slave trade, on the other hand, largely went further east to the Mideast and to Asia. So as African Americans, we don't have quite so much shared ancestry with East Africans. So we've been narrowing down the genetics of African ancestry linked to this risk of biologically aggressive tumors such as triple-negative breast cancers. We've narrowed it down to Western Sub-Saharan African ancestry. And it probably is related to some of the genetics that were acquired by our ancestors in that part of Africa to survive different infectious diseases that were endemic to that part of the continent. And so these lessons that we're learning in terms of the genetics of our ancestors and the genetics of the immune response to infections, they have a downstream consequence on the immune landscape of different organs. And this has an effect on risk for different types of breast tumors that we develop. And it probably has an effect on response to treatment. So we are actually very, very excited that what we learn about the genetics of African ancestry and how it impacts on breast cancer risk, it's probably going to teach us quite a bit about our immune system in terms of response to cancer, cancer biology. And these lessons are going to be important to all people in terms of cancer, because we do live in an era of immunotherapy today where we are trying to understand how the body's own immune system fights off cancer and contributes to response to treatments for cancer. So the work has been very exciting.
It's a new buzzword, not for you, but for the general public, immunotherapy. So if you'll take a moment and just, again, explain to our audience what immunotherapy really consists of. I know you just said it, but let them really understand again what that whole process looks like.
Thanks. So our bodies do have wonderful immune systems that fight off cancers all the time. Cancer at its root is a genetic aberration where some cells in the body start dividing beyond the body's own response controls. But we do make cancer cells all the time, and our body's immune system is able to fight those cancer cells off most of the time. But sometimes the cancers escape, they evade the body's immune system, and a cancer will take root in a particular organ. As we get more advanced in the arena of precision medicine. We are learning how to manipulate the body's immune system so that we can enhance our body's ability to fight off a cancer that has already taken root. And so we do have some immunotherapies that have been very successful, particularly for some of our more biologically aggressive breast tumors, such as triple-negative breast cancer. And the body's immune system, broad diversity, a lot of breadth there. So there's a lot more that we have to learn so that we can optimize our ability to manipulate the immune system better and help our bodies fight off cancers even more strongly.
So we talk about triple negative, and TNBC is a big challenge for Black women, as we've already spoken about. And I think for some people, they don't really understand what is triple negative. And so if you could talk a little bit about exactly what, they hear the word, but if you could help us understand definitively what is triple negative breast cancer.
So to put that in the context of a little bit of history, we used to, several years ago, think of breast cancer as just being one disease. And we didn't have very many ways to treat it except with surgery and maybe radiation. And in that era, breast cancer survival rates were poor. As we learned more about the biology of breast cancer, we came to appreciate that it's an entire spectrum of different breast tumor subtypes, and we can make tremendous strides in improving survival rates from these breast cancers by targeting the treatment to suit the particular cancer. We basically characterize any breast cancer by specific characteristics called the estrogen receptor, the progesterone receptor, and HER2/neu. These represent specific proteins that some breast cancers will manufacture. The most common pattern is for a breast cancer to be overproducing the hormone receptors, estrogen receptor and progesterone receptor, and to not be producing very much of a particular growth factor protein called HER2/neu. That's the most common pattern. And we have wonderful hormonally active cancer-fighting treatments that help us to eliminate the hormone receptor positive breast cancers because these are the most common cancers, so we have a lot of experience with treating them. We made wonderful strides in identifying therapies that target the HER2/neu growth factor protein. These are called anti-HER2 targeted therapies. The cancers that are negative for all three of those markers are the cancers that we refer to as the triple-negative breast cancers.
Triple, the three.
That's where it comes from. And because these triple-negative breast cancers are characterized by the proteins that they are not producing, we haven't made quite as much advance in terms of developing targeted therapies that will specifically focus on eradicating the triple-negative breast cancers. So these triple-negative breast cancers, unfortunately, are more deadly because we have fewer targeted therapies for them, but they are also inherently biologically more aggressive and more likely to metastasize. And triple-negative breast cancers are twice as common in African American women compared to white American women. They're twice as common in Black women, regardless of the age at which the cancer is diagnosed in the woman, and regardless of the stage at which the cancer is diagnosed. So there is definitely something about our African background that predisposes us to developing these biologically aggressive cancers. And seeing that these triple-negative breast cancers are even more prevalent in women on the Western Sub-Saharan region of Africa gives us more evidence to support the fact that there are some inherited genetic underpinnings explaining these differences in tumor biology.
You know, back in 2021, Sisters Network coined the Black breast cancer crisis because we as an organization feel that when we have this many women, particularly Black women, dying at alarming rates, that it's a crisis. We have too many young sisters that are calling our office, and we get over 3,000 calls per year from different women. I know that you as a surgeon see a lot of, of your patients come through, of a diverse group of patients, but are you seeing more young Black women coming, needing your services? And what does that do to you as a Black female surgeon who's been in this this business for a very long time, and you've seen the trends over this time. What does that do to you?
Yeah, it's a very painful thing to observe. Noticing these types of variations in the breast cancer patient population that I'm caring for personally is what drove me to become interested in dedicating my career to managing breast cancer. Back in the beginning of my career as a practicing general surgeon, I took care of a lot of different disease processes, benign, malignant, trauma, a lot of different surgical issues. But in Brooklyn, where my practice was based, a lot of women with breast problems sought out my care because they wanted a female surgeon, and there weren't very many of us around back then. So I kind of naturally developed a practice that was heavily weighted with Black women with breast problems, and it was just horrifying for me to see in my office day in and day out that my Black breast cancer patients tended to be younger. They tended to have the more advanced, bulkier tumors, and they tended to have their cancers recurring more rapidly despite the treatments that were available. So today we have learned a lot more about the biology of breast cancer. We have at least defined breast tumor subtypes, and we've developed better targeted therapies to improve outcomes from breast cancer. And we have great methods for early detection. So we have a lot of tools that have allowed us to reduce breast cancer death rates, but those death rates are still disproportionately higher in the African American community. And we are still seeing our younger Black women presenting with breast cancer. Breast cancer incidence rates are actually on the rise for younger aged women, and we don't know why. So it's very, very frustrating for me to see these same patterns persisting over the years. But I am still optimistic because we do have wonderful research tools available, and we have very exciting clinical trials underway to improve breast cancer treatments, to improve earlier detection of the disease. But we are facing many challenges.
Right.
We are still trying to recover from the severity of COVID and the impact of COVID on screening, with more women unfortunately having missed screening because of the hiatus that was placed on routine healthcare during the COVID pandemic. And as we try to emerge from those difficulties, we even had labs that were shut down during COVID, so there were cutbacks in the research that could be done in cancer as a consequence of COVID. And now trying to emerge from that, we're facing cutbacks in research funding overall, and especially for cancer. So,
which is very disheartening.
Very, very disheartening. And unfortunately, disparities research frequently seems to be the low-hanging fruit when it comes to cutbacks in research funding. And so we are seeing disproportionately excessive cutbacks to disparities cancer research.
So as a renowned surgeon, you're seeing these cases come through that need your assistance. We have many people watching this podcast. What would be a message that you want them to come across with before they end watching this?
Caroline, I would have to hearken back to the very first slogan, I don't know if you can call it soundbite, the very first theme of the Sisters Network Incorporated, Stop the Silence. We have to continue advocating on behalf of our community, advocating on behalf of disparities research, advocating on behalf of early detection, mammography screening, and taking advantage of other screening modalities that are out there. Stopping the silence and talking about this breast cancer burden that is disproportionately killing Black women compared to women of other racial ethnic backgrounds. We have to stop the silence, talk about it, and take action. Stop the silence means looking after your own health, being aware of breast changes. Mammograms are not perfect. They work very well in early detection, and mammograms work very well in detecting even the biologically aggressive tumors such as triple-negative breast cancers. So we do want women to get screened appropriately. We want women, especially African-American women, to get screened in reputable, high-quality centers. There's unfortunately an abundance of data showing that Black women are more likely to get their mammograms performed in some of the lower resourced, lower quality centers. They're more likely to have delays in working up mammographic abnormalities. So advocating on behalf of yourself means advocating on behalf of getting that screening done appropriately. But since mammograms aren't perfect, another message to the audience is that you do need to be aware of changes in the breast. If you have a new lump in the breast, lump in the underarm, bloody nipple discharge, changes in the skin appearance of the breast, those problems might be caused by benign problems, but you must seek medical attention and get it evaluated. Even if your mammogram a week earlier was completely normal, you do need to advocate on behalf of yourself. And if you're not getting appropriate answers from your physician or whoever your healthcare provider is, please do seek another opinion. Seek the Sisters Network out. The Sisters
Absolutely.
Network will advocate on behalf of us. So we need to work together and stop the silence and
normalize
take
the
care of
conversation.
ourselves.
We're trying to normalize the conversation amongst our young Black women in particular with some of our initiatives. But I think it's interesting what you just said about seeking an alternate physician to help you, and again, advocating for yourself. And so I know a lot of folks get the white coat syndrome, where they don't want to offend their physician or medical provider. And it's so interesting and appreciative to hear you personally say, it's okay to go and get a second opinion or to get additional assistance medically if you're not getting what you feel like you need.
Yeah, it absolutely is even more than okay. It's a necessity if you're not getting appropriate answers from your physician. And Sisters Network has always been a champion in making sure that women advocate on behalf of themselves. And I think that the white coat syndrome that you described, it in many ways is probably even more prevalent in the African American community because of the underrepresentation of physicians of color in the healthcare workforce. And unfortunately, we have huge progress that still needs to be made in terms of getting more Black physicians out there, more Black researchers out there. If we can do better and take advantage of that huge pool of talent and brilliance out there in the African American community and get these young people to pursue careers in healthcare and medicine and research, that in and of itself is going to go a long way in improving the science that we do and improving the care that we deliver to our patients. All patients, regardless of their background, will have more faith and confidence in the healthcare facility and in the healthcare system if they see healthcare providers that reflect their own families and their communities, and if they see a healthcare system and providers that have lived experiences that are more similar to their own. So we have a lot of work to do in terms of addressing the lack of workforce diversity that exists. So that's another area where we need to stop the silence. We need to talk to our young people and get them to pursue careers in healthcare and in the sciences.
And I know you're personally mentoring, a lot of, physicians, surgeons coming up the pipe. What do you tell them or share with them that they can't learn in the textbooks?
Yeah. I think the best thing to continue projecting to the young people is your own enthusiasm for the work that you do, and to show them how passionate you are about what you do and how rewarding careers in medicine and healthcare and research actually are on a personal basis. On a financial basis, physicians do tend to live reasonably well in this country. So there are a lot of reasons why young people should pursue careers in the sciences and in the healthcare. And unfortunately, we are lacking in getting more of our young people of color to pursue those careers. And I know that many of our young people are especially cautious or reluctant to pursue careers in healthcare today because of huge funding cutbacks that are making it difficult to pursue careers in the sciences, but we have to stay the course. And so I encourage all of the senior people like me to keep trying to reel these beautiful, talented young people into the fold and show them what an exciting field it is. And in breast cancer in particular, I know we've been talking about the heartbreak of disparities quite a bit. And it is heartbreaking. It is appalling that these disparities exist. We must eliminate them. But we have made huge advances.
Absolutely.
Breast cancer survival rates continue to improve because of better surgery, better medical therapy, including chemotherapy, targeted therapy, better radiation oncology treatments. We've made huge strides, and we do detect breast cancers early. So when we meet newly diagnosed breast cancer patients, we generally can tell them, you can beat this. You can beat this diagnosis. We have effective treatments. So we do want our young people to understand that the excitement in the field still exists, and it's incredibly rewarding to be a part of it.
And I know that, of course, professionally, you're, very esteemed in the breast cancer research and surgical area, but personally, it's touched you. And I think I'd love for people to know how that's touched you personally, if you don't mind just sharing a little bit about that journey.
The study of breast cancer disparities and the impact of breast cancer on women with African heritage has always been a very personal issue for me because of my own African heritage, obviously. But unfortunately, it became recently far more personal than I ever thought it would be or wanted it to be. As you know, one of the big explanations for breast cancer disparities between Black women and white women is related to socioeconomic issues and the higher rates of poverty and lack of insurance, lack of cancer care access in the African American community. But there are these potentially genetic and tumor biology reasons that we've also discussed. Well, we do have lots of evidence showing that socioeconomics aren't the exclusive answer. And that became especially apparent to me recently on a personal basis because of my incredible sister, Debbie. An absolutely remarkable woman in so many ways. Princeton graduate, Georgetown Law School, was a federal prosecutor for the U.S. government for many years. And then after she stepped away from her federal prosecutor job, she took on a whole new career teaching very disadvantaged students in the New York City public high school system. So much to give. Well, Debbie, and she was also very, very cautious about her health care, I would say. She always asking questions and always very careful about making sure that she took care of herself because she had an adopted son that she had to be there for, and he's also developmentally delayed. So my sister Debbie, just amazing. Well, a couple of years ago, quite suddenly, in a telephone conversation, she was slurring her speech. And the thought immediately was, of course, that maybe she was having some type of a neurologic acute event. We got her to the emergency room, and it turned out that she had brain metastases from triple-negative breast cancer. And she had not been diagnosed with breast cancer before. Her presenting sign of a breast cancer were the neurologic manifestations of the brain metastases that she had. And we've made wonderful strides in treating breast cancer, but none of them were in time for Debbie.
And how old was Debbie?
She was 67.
67.
Passed, and we lost her, but incredibly active
Yes.
67. Yes, still had so much to give. And we lost her at about 2.5 months because of the aggressive nature of this disease. And Debbie had a lot of reasons to be proud of her wonderful career and education and everything that she's done. She was also very proud of her genetic heritage. She did the 23andMe test several years before she passed away, and she was so incredibly proud to see that our family's African roots were from Ghana. And that was especially poignant to us because the research that I've been doing on the continent of Africa has been heavily rooted in working with some wonderful cancer colleagues in Ghana at the Comfort Teaching Hospital in Kumasi, Ghana. So Debbie found that it was very, very special
proud
to
of her
learn that
sister.
through my sister. Yeah. But
Well,
we lost her way too soon, and she's a perfect example of how these breast cancer disparities between Black women and white women are not exclusively explained by socioeconomics. Debbie had all of the advantages, and this triple negative breast cancer
found its way.
hit all of us like a sledgehammer when it afflicted her so horribly.
Well, I thank you for sharing Debbie's story, and I know that her memory is always a blessing to you, and I guess also adds another layer of fuel to what you do. So I thank you for that. Just let's talk about briefly compassion care and how do you implement that into your practice when you're, because some doctors are not as compassionate as we would like, and so why is that important from a patient perspective?
That's a great way of phrasing the way that all doctors should be practicing every day, compassion care. It's unfortunately way too easy, I think, for many doctors, especially as they become more senior, to start feeling a bit jaded, maybe frustrated with the system. There are a lot of inefficiencies in the system, and there are a lot of things that we would like to improve that maybe we don't feel that we are empowered to improve. And unfortunately, that can take a toll on the way that physicians perceive what they do. And that has an impact on the way that they interact with patients. We have to remember that the trust that patients place in us, because of all of the years that we put into our education and training, that trust has to be re-earned every single day and with every single patient interaction, no matter how long you've known the patient. You have to keep re-earning that trust. Part of re-earning it is through what you just described, compassion care, showing the patient that you care about them through your mannerisms, through face-to-face contact, eye-to-eye contact, and talking to the patient, their family, making sure that the patient's support network, whoever that may be, is included to the extent that the patient wants and needs to have them included. It is a team effort in many, many ways to treat a cancer diagnosis.
Yeah. Well, let me just say this. You have been 10 toes down with Sisters Network since I can remember. Again, 25 plus years, and we can't thank you enough for that. I guess I'd love to know from your lens, why is an organization like Sisters Network Incorporated so important to the community and the work we do?
Sisters Network Incorporated is essential to the community here domestically in the United States, to the world. For as long as I can remember, Sisters Network Incorporated, through your incredible, magnificent mom, Karen Eubanks Jackson, Sisters Network has been fearless and tireless in promoting messages about breast health awareness and stopping the silence about breast cancer disparities, advocating on behalf of the African American community for early detection, mammography screening, being aware of breast changes overall, supporting research. Many of the chapters in Sisters Network have supported my research by contributing to the biobanking that we've done and the research that has taught us lessons about differences in tumor biology between Black women and white women. We can only do that type of research by having women contribute to research. So I so appreciate the way that Sisters Network Incorporated has always promoted awareness of research and advocated on behalf of African American women contributing to that type of research. So I thank you from the bottom of my heart.
Thank you. Thank you. You talked about research. With the rise of AI and the evolving imaging tools, are we getting closer to saving lives?
I believe that we are. I truly do believe that with advances in AI, with advances in genomics and genetics, that we can we can ultimately figure out the root causes of cancer, especially breast cancer. I do think that it's within reach, but it is going to take massive research funding, and it will take large populations of people being willing to contribute to that research, whether that's contributing financially or contributing in terms of allowing your tissue specimen to be part of a biobank. There are a lot of different ways of contributing to research. At the same time, the research tools that are available are frighteningly at risk for magnifying disparities. With AI, we have the promise of utilizing many, many, many thousands of data points to try to understand cancer biology and to try to predict who is going to develop a cancer. For example, using AI to help understand the various densities on a mammogram can potentially help us to figure out who those 13% of American women are that will get breast cancer at some point in their lifetime. That is the power of AI, to try to use these data points for prediction as well as identifying better treatments. However, if we are utilizing those AI techniques and only studying small snippets of the global population and snippets of the population that are very uniform and non-diverse, we're going to magnify the disparities that exist because we will be missing so much.
So magnify in a negative way?
Correct. Because if we are looking at thousands and thousands of data points, but in only a population that's very homogeneous, and we are excluding the data points from diverse patient populations, we are missing a lot of data that could be informative in terms of understanding and contributing to eliminating the cancer burden of people on a global basis.
And despite all the data, the grief, the disparities, what gives you hope right now?
I guess a couple of things give me hope. A lot of the research tools that are available, as you were so eloquently listing just now, and the young people. I think that the young people and the way that they have embraced the internet and social media to make the world a smaller place in terms of our ability to communicate with communities around the world in the palm of our hands with our cell phone, our devices. Seeing the way that the young people have embraced those technologies, that gives me huge hope for the future. I see nothing that these brilliant young people, you young people, can't accomplish. I'm so proud of you.
Thank you. Thank you, Dr. Newman. And lastly, I know we said stop the silence is a message that you would like to convey to the folks watching. But what advice specifically would you give to a Black woman listening who might feel overlooked, dismissed, even afraid?
Please, please understand that with regard to breast cancer, I know that there are a lot of health disparities out there. With regard to breast cancer, I can't emphasize strongly enough the power of mammography screening. Please get your mammograms starting at age 40, continue them every year. If you are at high risk because of a strong family history, or if you've had a breast biopsy showing that you are at higher risk because of overactive breast tissue, if you have features on your mammogram indicating a higher future risk of breast cancer, please, please do be mindful of that and make sure that you take advantage of the other modalities that are available to protect yourself from the threat of breast cancer. You might be a candidate for a whole breast ultrasound in addition to mammogram screening. You might be a candidate for breast MRIs in addition to a mammography screening. And then there are other modalities out there, contrast-enhanced mammography, a lot of wonderful modalities out there to help us early detect breast cancer, and early detection of the disease does make a difference. Our own research with our international studies has demonstrated very conclusively that early detection with mammography of triple-negative breast cancers makes a huge difference in survival rates. But we also need, for the African American community in particular, to be aware of the family history and the family pedigree. We have some very exciting breast cancer targeted treatments that are especially suitable for patients that have BRCA mutations. These are targeted therapies for women that have BRCA mutations.
And that's a genetic.
Yes, the BRCA1 and BRCA2 are genes where if you have particular mutations or abnormal patterns in these genes, it can increase the risk of getting breast cancer or ovarian cancer tremendously, 35 to 85% lifetime risk of getting those types of cancers if you have these mutations. The African American community, unfortunately, has had lower genetic testing rates, even with strong family histories.
Do you think we don't want to know?
Well, that might be a part of it. And this is, again, where we have to stop the silence. We do have to talk to our families and find out about the history. Unfortunately, a lot of the disparity in genetic testing is the fault of the healthcare provider community. Genetic testing is offered at disproportionately low rates to African Americans, and that contributes to some of these disparities. But it's important to know because you can utilize the information to take better care of yourself and to take better care of your family.
Okay. Well, Dr. Newman, you have given us not only science today, but your strength and your passion for saving women's lives, all women's lives. And we thank you for that. Your work continues to transform what's possible in the fight against breast cancer, particularly for Black women. And we're just honored for you to be here with us today on our inaugural podcast. So we thank you from the bottom of our hearts at Sisters Network. This is a woman who's been 10 toes down with Sisters Network and does wonderful work. So if you're in the New York area and you do have any kind of breast health issues in terms from a surgical standpoint, Dr. Newman
to me anytime.
She's your girl.
And it is an honor to be here with you today and to have been with you and your mom on this amazing journey.
Thank you. And for our listeners, share this episode, get informed, and be your own best advocate. Visit sistersnetworkinc.org to learn more about the work that we're doing around the country. And let's stop the silence so our sisters can start beating the odds.
The motivation working in oncology is easy. I think we all have a family member or a friend that's affected by cancer, and you just know the toll that takes on not only that person, but their family.
While I might not today be in one of those situations where I desperately need a medicine for someone I care about, millions of people are all over the world in that exact situation. Like, we are the people who make those things.
No shortcuts, no compromises. We discovering, we identifying, we applying cutting-edge technologies and the methodologies in our daily work.
Whether I can improve with new technology, doing something faster, I'm always trying to get better in every experiment that I'm running.
I think we constantly have to be pushing those boundaries, not just so that we can stay at the forefront as a science and technology company.
Being bold with ideas can really help us make breakthroughs and bring us step closer to discovering effective treatments for patients.